In this episode of Medicine Across a Lifetime, let me open with something simple. We measure blood pressure. We track glucose. We calculate risk scores. But when was the last time we measured connection? An older patient recently came in with fatigue. His labs were stable. His chronic conditions were controlled. There was no urgent finding. On paper, he looked well managed. Then I asked him what his days looked like. His spouse had passed. He no longer drove. Most of his day was spent alone. He told me he was fine. We both knew that was not the full story. Depression in older adults does not always look like sadness. It can present as poor sleep, appetite change, irritability, slowed cognition, or frequent medical visits. Anxiety may appear as repeated reassurance-seeking or persistent health worries. Too often, we label these patterns as normal aging. They are not normal. They are treatable. A significant proportion of older adults live with a mental health condition. Social isolation increases cardiovascular risk and mortality. Suicide rates remain highest among older men. These are not secondary issues. They directly influence outcomes. Cognitive behavioral therapy is effective in older populations. Mindfulness practices reduce stress and improve regulation. Structured social engagement strengthens resilience. Yet behavioral health referrals are inconsistent, and many systems still treat mental health as separate from primary care. Medication plays a role. But medication does not replace connection. So perhaps we need to redefine stability. Stable should not mean only controlled laboratory values. Stable should include emotional resilience, meaningful interaction, and psychological safety. There are practical steps we can take immediately. Screen routinely for mood disorders. Ask at least one question about daily connection in every visit. Identify barriers such as transportation, mobility, or hearing impairment. Develop clear referral pathways. Follow up with intention. This is not about adding complexity. It is about sharpening our clinical lens. There are ethical and professional responsibilities here as well. Failing to recognize depression or anxiety in vulnerable older adults has real consequences. Documentation matters. Follow-up matters. But more than anything, attention matters. Let me ask you directly. In your next clinic session, will you ask about connection? If this perspective resonates with you, leave a comment about what you are seeing in your practice. Share this episode with colleagues who care for older adults. Start this conversation in your department. Bring it into leadership discussions. Isolation is not inevitable. Depression in aging is not a rite of passage. Anxiety is not simply personality. We have the tools. The question is whether we will use them. Thank you for joining me for this episode of Medicine Across a Lifetime. Continue asking better questions. Continue expanding what stability means. And continue leading care that honors the whole person across a lifetime.